Dear colleagues, this is an intumescent cataract with mid-dilated pupil. The main challenge in intumescent cataracts is capsular rhexis because there is high chance of rhexis runout. To prevent rhexis runout, many colleagues use preoperative mannitol and intraoperative sodium hyaluronate as the viscoelastic substance. I don't use any of this. I don't use preoperative mannitol, and I use only hydroxypropyl methylcellulose 2% as the viscoelastic substance. In this case, the main incision has been made, one side port has been made, and now the capsule is being stained with striped blue dye. Now I wash the dye out. I have asked for some adrenaline to see if the pupil dilates little more. And here is the adrenaline. Intracameral preservative-free adrenaline epitrate from Sunways. No financial interest. Now viscoelastic substance HPMC is injected. In this case the people didn't dilate with adrenaline much, but little bit, about 0.5 or 1 millimeter it has dilated, and that will be helpful. Now see what happens. As I incise the capsule, some fluid comes out. Some turbid fluid come out. Now I hold the capsular tag and make a small rhexis at this stage. This is a uterata forceps, and it is very easy to do a small rhexis like this at this stage. There is a lot of margin of safety if we do small rhexis. And now a lot of loose cortical lens matter is there. Those are aspirated through this opening with a Simcoe cannula. One can use a bimanual IA if he or she wants. And now HPMC is injected again. Now a venous scissor is taken and a small cut is made at the margin of this mini rhexis. This cut in this case is at around 7 o'clock. Now the rhexis is enlarged without any fear of Argentine flag sign, without any fear of rhexis runout. I'm going almost along the border of the pupil to get an adequate sized rhexis. And it has been a circular rhexis comparable to femtorhexis. And now is the time to manage the nucleus, to go into the eye with the phaco handpiece. The machine being used in this case is Oatley Cataracts 3 from Switzerland. Nice machine, no financial interest, but the very good hold. It holds the nucleus very firmly. And this is the easy tip. And I'm going to do direct chop. The nucleus is impaled and held very firmly, and the nucleus is chopped. The nucleus is rotated and it is chopped again. Now see the pupil is tending to become small occasionally. As soon as the intraocular pressure becomes less, the pupil tends to become small. So what I am planned is I'll chop the nucleus totally, and after chopping is complete, I'll remove the chopper and emulsify the fragments single-handedly without help of the chopper, and this will keep the pupil dilated. Sometimes in between we may have to use the chopper just to position a large nuclear fragment. Phaco power being used is 70%, flow rate is 45 ml per minute, vacuum is 450 mm of mercury. And here is the last nuclear fragment emulsified. And now is the time for cortical cleanup. Viscoelastic substance is injected, and now a 23 gauge Simcoe cannula is taken, and the cortical cleanup is done very comfortably. This is a very thin Simcoe cannula, 23 gauge. It goes to the side ports very easily. And now the cortical cleanup is almost done. We must be very meticulous in every step of surgery. You can see that the posterior capsule is clean, there is no cells. Now this is viscoelastic substance. When the pupil is not well dilated, we must use viscoelastic substance, and it will cause some dilatation of the pupil. It is called viscomydriasis. Now a single piece intraocular lens is implanted in the capsular bag. The chopper helps the trailing haptic to go into the capsular bag. Now the lens is dialed and placed in a nice way. Now the viscoelastic substance is thoroughly cleaned, first with Simcoe cannula and then with irrigation aspiration, bimanual irrigation aspiration. In this case, a lot of air bubbles somehow went into the antechamber. Now how to remove this? We cannot go very close to the corneal endothelium and aspirate this with the Simcoe. So what can be done is take the irrigating probe of bimanual IA and direct the jet of fluid towards these air bubbles. Like this. The air bubbles mobilize and mobilize the air bubbles, and the air bubbles come through the main incision. Thorough cleaning of viscoelastic substance is a must. Otherwise, intraocular pressure may increase and the patient may have even pain in the eyes. Though it can be managed medically by acetazolamide or timolol maleate, but we should meticulously remove the viscoelastic substance. Now the side ports are hydrated. so that these wounds become waterproof. And finally, an antechamber lavage is given with Simcoe cannula. So after thorough cleanup, after final lavage, the antechamber is formed and the case is concluded. Thank you very much for your attention. Hope this video will help you in your practice.